Welcome to Adapt NCLEX, and thank you for joining us. So today we're going to work on fundamentals case study. We're going to go through all the information that you need to know, key facts that we're going to talk about, some basic fundamentals in the case form. Let's get to it. So what do you have? You have a 68 years old client, right? He has a history of COPD, history of stage 2 pressure ulcer, and then reflux and hypertension. Patient was admitted because of shortness of breath, poor oral intake, and decreased mobility. Think about it. I'm trying to get you to a place based on those stories. So you just have to put them together and figure out what is wrong with this patient as you go along. But just go with the flow. Don't worry about it. Don't worry about what you need to do. Just there will be something there for you to think about. Patient has penicillin allergy. Start thinking about what you have in front of you right now. And then a patient has full code. Basically, patient has full code. That means if anything happened to the patient, we got to do everything to bring the patient back. So that is key, right? These are the patient vitals. And you can see the slightly patient has a fever, blood pressure expected because the patient has a hypertension, but it's not controlled. We don't know. Tachycardia, that should tell you something, that probably the patient is dehydrated, right? Respiratory rate of 24 and saturating 88% on 2 liters. So this is what you have on the patient. And these are the lab work. You can see the sodium is borderline, but still normal. Potassium is 3.2 and creatinine is 1.1. 60-year-old patient, bunch of medical problem. These are all chronic diseases. This is the reason why the patient was admitted, but shortness of breath, poor oral intake, decreased mobility. You can start thinking, older patient with all this problem, something is not right. What do you think we should be thinking about? Yes, allergic to penicillin. And then the code status is full code with the following vital. If you put all these things together, then what do you think we should do for this patient in terms of these orders? This is the orders that was given. Insert NG2 for decompression. Tracheostomy with sanctioning at the PRN. And then IV access, right? Pressure, injury, wound care, and then a fall precaution. And tend the patient every 2 hours, right? And then give the patient albuterol, some furosemide, and enoxaparin, and acetaminophen. I'm trying to present present fundamentals of nursing in the different ways so that you can see all this information I'm giving you is very important. You may have to use it, but this is a very short fundamental of nursing in case you see a question, and you can master your content just by this case study. So these are the things we have given. Which action should the nurse implement to maintain client safety and prevent fall? You saw all the conditions the patient have, other issues they came in with. What do you think we should do to prevent the patient from falling? Should we keep the bed in the lowest position? Should we place light within the patient reach? Should we allow the NG tube to hang freely from the IV? Or should we encourage the client to walk without ambulation? Or what? Use a non-slip socks. And then ensure that tracheostomy suction catheter is at bedside. What do you think? These are the actions you want to take. Is it acceptable or not acceptable? You can put it in the answer choice, but this is a safety question, right? Forget about a case. When you see something like that, don't worry. Forget about this is a case. All I'm asking is, what are the safety precautions you can institute to prevent the patient from falling? They can turn this and they said, which of these you should not do or you should do to prevent fall? What do you think? Which of these are fall risks? Of course, the bed in the lowest position is good, right? Prevent fall for the patient. Then light within the patient reach, place the light within the patient reach, the call light and everything. That will prevent them from getting out of bed. And then what? Allowing NG tube to hang freely from the IV pole. What do you think? If the NG tube hang freely, the patient can trip on it. That's a fall risk. They cannot walk without assistant. It's not good. At least walking with assistant is good. And then non-slip socks, of course, that's a good one, right? And then having tracheostomy suction at bedside. So these are all things that will help the patient and it will prevent the patient from falling. So bed in the lowest position is good. Core light within reach is good. IV NG tube hanging freely is not a good idea, of course, right? Walking alone is not a good idea in this patient with multiple problems, right? If they have a non-slip socks, it's a good idea. And then making sure we have suction at bedside. These are our safety for and safety precaution in that patient. So this is a safety question. That's all it's designed for. Now, we have pressure injury question. Which intervention is most effective to prevent worsening of the sacral stage 2 pressure injury? The patient has pressure injury. What can you do to institute to prevent the patient injury from getting worse? And this is one of the most important things. Like anytime a patient come in, assess them. When you assess them, you look for pressure injury. When it's a pressure injury, you prevent further progression. What are we preventing? We have a stage 2, and you should know the stages of pressure injury, like stage 2 injury, where you have gone to the dermis, right? There's some blisters associated with it. It can progress into stage 3, where now you're going down, you're getting full thickness into the fat. When you get to the bone, you're in stage 4. Then the last one is unstageable. We can figure out what kind of stage is that. So what are the things you can institute to prevent progression from that stage 2? You give the patient some donut to sit on it, reposition the client every 2 hours with the draw sheet, keep the client in a semi-final position at all times, and then massage the reddening areas twice daily. Which of these are actions have you seen before or you read about it, then apply to prevent pressure injury? You give them donut to sit on it, or you reposition them, right? You keep clients in the semi-final position, right? Or massaged the reading area twice a day. Of course, if you massage areas that is red already, is going to progress and you're going to worsen their sacral decube. Donut will put too much pressure. It's always a misconception. Donut are not good in this in the management of stage 2 or pressure injury. Keeping them in the semi-final position at all times, you contradict the number 2. Number 2 said reposition. 3 said keeping them at one place. So sometimes when you see questions, you'll be able to figure out the answers by looking at something that is contradicting each other. So 2 and 3 are not talking to each other. They hate each other. Therefore, 2 has to be the right answer, right? So that's what we do. Now, you saw the client, his saturation is 88% on 2 liters. Which action should you think you should take? 6 liters or nasal cannula. So how about this is 6 liters. We just make it 6 liters nasal cannula immediately, or you encourage deep breathing and assess lung sounds right away, or call the respiratory therapist, or place the client in the prone position. Patient saturation 88% on 2 liters. What do you think you should do? The key to answering this question is to look at the history. The patient has COPD. Too much oxygen is not good for them. And usually, too much oxygen does not help them. So you can see if you increase the oxygen flow to 6 liters, it's not going to help them. It's going to worsen their condition. Right? Putting the patient in the prone position is not a good idea. Right? Calling the respiratory therapist, you can do something. Always assess the patient. Figure out what is the problem. Can they take a deeper breath and improve the oxygenation? If not, then you can increase the oxygenation. But the best way is to assess them rather than increasing oxygen by changes to 6 liters. But this is a little fundamentals information you shouldn't forget when you see questions. Now, I'm taking you deeper, right? A nurse is preparing to administer enoxaparin, 40 milligrams. First, you got to identify the medication. What kind of medication is it? Then, what do you think? What action should you take? What is enoxaparin? Enoxaparin is a low molecular weight what heparin. And low molecular weight heparin, how do you inject it? It's an anticoagulation. So what do you think? Where do you inject it? How do you inject it? What are the fundamental things you need to do? And how do you apply it? So this is the question. Do you inject it at 90 degrees? Do you inject it what? At 45 degrees, as you can see? Or do you inject it at 12 degrees? Or 25 degrees? How do you inject enoxaparin? It's an anticoagulant. And where do we inject it? You got to take that into consideration, just using the imaging, right? And how do you inject it? Which angle? And what kind of needle do you use? This one, I'm not asking you the needle. I'm just asking you, what way do you inject it? There's a content here. If you don't know it, it's fine, but we learn it, right? Whenever they ask you about this kind of question, think about where is the medication going? And Enoxaparin is a heparin lower molecular. We inject it sub-Q, right? But whenever you are about to inject medication sub-Q, there's two things. Think about the weight of the individual. If you're obese and you cannot pinch the skin 2 centimeters, if you cannot pinch 2 centimeters, that means they're too thick, then you got to inject it at 90 degrees. But if you can pinch 2 centimeters, that means you can inject it at 45. So this question is designed to teach you, like, I did not give you the weight, but the most common one is 45 degrees. But if you can inject and you can pinch, you cannot pinch 2 centimeters, then you make sure you inject it at 90 degrees. For this one, we think we can inject it at what? We can pinch almost 2 centimeters. So once again, a 2 centimeters pinch on the skin. That means you can grab the skin about 2 centimeters, then you can inject it at 45. If you cannot pinch it at 2 centimeters, then you have to inject it at 90 degrees. So for this one, 45 degrees is the best one because I did not give you the weight. Now, the client needs suction. You have to know suction. If you want to learn fundamentals, all these little things, we went from safety, we went from fall, and we went for what? Injection of medication. And now we're talking about suctioning. How do you suction patient? What are the key aspects? Like I told you, one video has all a bunch of concepts in it. What are the things you need to know about suction? What techniques, which interventions do you have to apply? Selected apply. Do you pre-oxygenate the patient before that? What do you think? If you know the answer, you can put it in the comment. Do you have to pre-oxygenate patient before you suctionate them? Do you insert the catheter all the way into the trachea? Think about it. Do you apply the suction while inserting the catheter? Do you suction them continuously for like 25 to 30 seconds to suction them? Or do you apply patient saturation? Do you monitor the saturation and the heart rate? Or you apply a pressure of 100 to 120 during suctioning? What do you think? So this is something that you may see and you have to know. Anybody who get suction need pre-oxygenation because when you suction them, you making them more hypoxic. You collapsing their airway. And so you got to pre-oxygenate them so that they have more oxygen reserve to take care of it. So this is good. Right. Inserting the catheter all the way is not good, right? You know, it's not a good idea, right? So that's not good. How about number 3? What do you think? Apply the suction while inserting the catheter. Is that what you do? Have you seen somebody do that and you correct them? No, you don't apply suction while inserting. You apply suction when you're withdrawing. So applying suction while inserting catheter is not a good idea. And suction 25 to 30 seconds is too long, right? 5 to 10 seconds. That is enough. So this is not good. You still, of course, you got to monitor if they're not doing well, their saturation and heart rate. And as an adult, 100 to 120 pressure is applicable. So this is good. So which one? Pre-oxygenate the patient is good. Don't insert catheter all the way to the trachea. Don't apply suction while injecting. Your suction should be just 5 to 10 seconds. And then you need to monitor the patient's saturation and heart rate. And then the pressure application is usually 100 to 120. So 156. You don't have to pick everything, right? If those that you know, you can pick it. If you know only one, you pick it. There's 3 answers there. If you pick more than that, you lose a point. There's 3 correct and 3 wrong. If you over-select, you get 0. But these are key concepts about suctioning, and you have to wait 1 to 2 minutes after you suction them, then you go over again. Like I said, one question, yes, everything you need to know about suction, and this is fundamentals of nursing. So that's what we now. Now, what do we do now? Next step is what? The client refuses NG tube. Remember, you have an order to place the NG tube because patient is more nourished and we want to feed them, right? The client state, I don't want this tube. What is the next best action? Patient, you need to place NG tube. And he said, no, I don't want the NG tube. And you know they need the NG tube. What actions do you take? Go back to ethics and fundamentals. Now, the videos on ethics, these are the things you have to like master them. You insert the tube to prevent dehydration because the patient is dehydrated. The patient said, I don't want a tube. Do you assess their decision-making capacity and document their refusal? Do you think is a good idea? Do you call the provider to override client refusal? Call the doctor and say, hey, patient doesn't want it. Can you come and override it so that I can go ahead and insert it? Or do you explain the 2 feet is mandatory for hospital policy? You tell the patient, hey, you need to take the NG2 because we have, it's part of the hospital policy. If you need feeding, that's what we use. What do you think? Do you tell a patient like that? This is ethics 101 in your NCLEX. If you go there and they ask you a question and the patient said no, no means no. You don't do anything. You pick an answer and say, okay, autonomy is an autonomy. It does not change whether you more nourished or whether you live alone. The patient said no. If he said no, then no. There should be no ifs or buts. So yes, we should assess their capacity first and make sure they understand what he's saying. Are they just saying because they're mad? So assessing the capacity of the individual is very important. Then if they refuse, then you can write it down. You cannot just jump on it. Assessing capacity means, hey, you know what you're saying? We got to give you NG tube. And you got to make sure they're not confused. They know what they're saying. They need to. 4 is a trap, right? Hospital policy does not trap the individual autonomy. Individual autonomy is the most important. You don't care about the hospital, even though you work there, right? And number 7, now delegation. Let's go to delegation. The next team is made up of what? We have an RN, we have an LPN, and a UAP. Which tasks do you think we can give it to UAP to take care of this patient? Tell the patient because we want to prevent the pressure ulcer, like every 2 hours. What do you think? The UAP can do that? And then monitoring the NG tube output and the residue. Who should do that? The UAP? And assisting the client to walk with the guilt belt. You give that to UAP? And let the patient get a zapper and Subcu. Who is going to inject it? The UAP. Reporting any pressure area that is red to the nurse. Who do you think should do that? And then reinforce teaching on incentives perimeter. I know you know delegation assignment. It's just straightforward. You have your method. I have my method. I can tell you the easy way for UAP is ADLs. And anything that does not require any thinking. That's all. It does not mean they don't think, but focus on ADLs and anything that does not require thinking. So this is a selected apply, which actions can be delegated safely, which tasks can be delegated safely to the UAP. What do you think? Which of these are activity of daily living, right? Turning the patient every 2 hours. Excellent. That's what you need, right? The turning will help with that so that the LPN can do something else. So one is right. Monitoring NG tube output and residue, they cannot do that. UAP, I said anything that does not require thinking. So they cannot monitor NG tube output or residue. That should be done by the LPN. They can assist the client ambulating with the give birth. So that's ADL. They cannot give the enoxaparin. Administration is negative. They can report if they see areas that is red in, they're not doing assessment, but they telling the patient, they said, this is red. I can tell the RN. So 5 is also good. They cannot reinforce teaching. So this is one of the things you got to master. I know you know them. So reposition is good, right? I can help you ambulate. And if I see bad stuff, I can let the RN know. But otherwise, the rest, they are not out of the scope of the UAP. Okay, so those are the things. If you get them wrong, just you got to master them. Monitoring, reinforcing are usually done by the LPN. So this is a straightforward delegation question. Now, what do you think? The next one is now we got to figure out what we need to do with the patient now. Rank the following issues from the highest to the lowest. We saw the orders that was given, and so now we have them back. Saturation, patient respiratory rate is like what? Saturation is 88% on 2 liters of nasal cannula. Which one should you address first? That one, sacral D cube and potassium of 3.2. Then the NG tube, patient refused the NG tube, and you got to give the patient enoxaparin. If you have to rank these, if you want to prioritize, which information do you assess first? Like which one should worry you first, right? What do you think? Which one is the most important to assess first? The saturation, that is 88, that is low, even though they are on 2 liters. And then sacral D cube or potassium 3.2, and then refuser and enoxaparin. What do you think is the number one? What do you think? I know a lot of people will choose potassium, but remember the patient has saturation of 88. It's not rumor. 88 on 2 liters is not responding with this. So I got to figure out why his sat is low. So I'll do that one first. Then I'll go to the potassium and deal with the potassium, right? That is the what I would do, potassium. Then I got to figure out, we got to provide nutrition, right? NG tube refuser, I got to deal with it. Then before the sacral D cube, then enoxaparin. So if the patient has there was no oxygen here, yeah, the potassium will be number one. But for this patient, he's on 2 liters and his sat is still 88, even though he's a COPD patient. We got to do this one first. Then we come then deal with the potassium, probably because of the dehydration. We got to provide some nutrition, right? And take care of the sacral D cube and then inject the patient. Sometimes you have to prioritize based on a condition, not based on the numbers. Okay, so prioritization based on condition. So the next is assisting the client with what? Left leg weakness now during the physical therapy. And teaching safe cane use, right? You know if the patient is weak, which action demonstrate appropriate client use of the cane. Now we're teaching the patient how to use the cane. Patient has left-sided weakness. Pay attention, left-sided weakness, and we want to teach them how to use the cane. What do you think is the next thing we should do? How do you do that? Hold the cane on the left side and move the cane forward 6 to 18 inches before stepping forward. Do you hold the cane 6 inches lateral to the base of your fifth toe? Do you place both feet together before advancing the cane? Or the cane is level to the greater trochanter? The elbow rests at 30 degrees. So these are the things the client is doing. He held the cane on the left side. Is it a good thing? He moved the cane forward 6 to 10 inches before stepping the left leg. He stepped with the right leg first and followed with the left leg, then the cane. The cane was held at 6 inches lateral to the base of the fifth toe. And he placed both feet together before advancing the cane. And the cane is level to the greater trochanter. Elbow is at 30 degrees. Assistive devices. I know you know it. This is in the question form. In the case study, patient has what? Left-sided weakness. Pay attention. Before you pick your answer, you got to know that patient is weak on the left. So what or which action is appropriate? If they're doing something bad, then it's a wrong answer. So what do you think? The cane is held on the left side is a wrong thing. You shouldn't hold the cane on your weaker side. It should be on the stronger side. So that one is wrong. One is wrong. Move the cane forward 6 to 8 inches before stepping with the left foot. Yeah. Usually you advance the cane and the weaker side together, but most of the time the cane go, then the weaker side follow so that you don't fall. So 2 is a good thing, right? Stepping with the right leg first, which is the stronger side, is bad. You're going to fall because the left leg will be standing there. So that's bad move. The cane is held 6 inches lateral to the base of the fifth toe. Yeah, close to you, that's where it's supposed to be. And place both feet together before advancing the cane. Wrong answer. You're going to fall, right? The feet should be far apart. They can't be together. So number 5 is wrong. The cane is level to the greater trochanter. Right move. That's the place where it's supposed to be. Excellent. Your elbow should be what? At 30 degrees, right? So there's 4 answers there. You don't have to pick everything. Those that you're 100% sure, you pick it. 7 is right. Elbow rests at 30 degrees. The cane is level to the trochanter. Those are the basics you have to know. Then go to number 1. Number 1 is wrong. It should be on the what? The stronger side, which is the right side. So that's wrong. Number 2 is right. You move the cane forward, then the weaker side starts with it. So that is good. And then number 3 is absolutely wrong. You can't move the stronger side first. You're going to fall down. And 4 is right. The cane is held closer to the little toe. And placing both foot together before advancing is not a good thing. So you shouldn't move with it. The client is being discharged home now. You remember, a COPD patient. We're talking about oxygen. You have to know these little things are put it together. These are basis of fundamental of nursing. They ask you in nursing school or in the NCLEX. It's very, very important. What do you know about oxygen safety? Oxygen safety. If you see somewhere, after this question, if you see any question anywhere on oxygen safety, they're going to ask you the same thing. Do you keep the oxygen tubing 5 feet away from the heat source? What do you think? Oxygen, fire. And I have a heat source. I should stay away from it, right? I can use petroleum-based product around my nose and lips while on oxygen. Well, you want to catch fire? I don't know. Think about that. You check the oxygen supply daily, ensure adequate flow. Yeah, so that the tank is not empty while you're still using it. Clean humidifier per manufacturing instruction to prevent infection. Follow the instruction. Nothing wrong with it, right? And then plug in oxygen concentrator extension cord and the rag to prevent tripping. 5 questions. Some of them are trapped. What do you think? If you have a patient who is on oxygen, what do you tell them? These are fundamentals things you need to tell them. First, they need to prevent fire. So stay away from fire. Number 1 is right answer. 2 is a trap. They always forget, but petroleum, it can catch fire. It can catch fire. So don't use petroleum product. Otherwise, your face will be on fire. So 2, they shouldn't do that. Check the oxygen supply. Make sure your tank is not empty, right? And then clean it based on the instruction given to you by the manufacturer. Your oxygen cord should not be under the rag. That's a trip problem. You shouldn't do that. So 5 is wrong, and then 2 is also wrong. Right answer is 1, 3, and 4. But these are oxygen therapy information that you can provide for the patient in terms of safety at home. Almost done. Now, somebody went home. They want to make sure, remember the patient has COPD, is weak, is malnourished. The tracheostomy, we got to take care of. So many things, right? And then he's going to use cane. We got to go check and make sure the home is safe. I'm taking you there. Safety at home. So the nurse perform home safety check on the client 2 days later. Which of these should you concern you? The aerial rug is taped at 4 sides. Everything is taped. The oxygen tubing placed under what? Furniture for neatness. The cane within reach of frequently used areas. Electrical cord ran across the walking path. And a fire extinguisher is accessible in the kitchen. What do you think? Which of these is good? Of course, if the fire extinguisher is within reach, hey, we're going to take care of fire, right? Otherwise, what do you think? What do you think? Aerial rag taped at 4 sides, right? It's all taped at 4 sides. I don't want any aerial rag on there. You can trip on it. Even though it's taped on 4 sides, it's still a trap. Just take it away. I'm worried about it. Unless they say it's very thin aerial rag and tape on all sides. But so far as it's still there, I never tell you it's very thin. It's still aerial rag. You can trip on it no matter what. It's a trap, right? Oxygen tubing placed under the furniture for neatness, well, bad idea. The cane is within reach, is good. The patient can reach it easily, right? And at the frequently used area. So 3 is good. Electrical cord ran across the walking path, bad idea. And a fire extinguisher accessible in the kitchen is good. These are fundamental questions. They can be trappy, but you got to think about safety, safety, safety. Well, I don't want to have aerial rag, whether you tape it or not, unless it's very tiny, thin area, but this is a full aerial rag tape 4 side, I still can trip on it. Oxygen tube should not go under the furniture for what neatness? No, it's to stay away completely. You know, still can trip on it. The cane is within your reach, so wherever you are, you can catch it. So that's good. Number 3 is good. Electrical cord on the pathway, we're going to trip. Fire extinguisher is in the kitchen. I can get access to it and take care of the fire. So these are little things I want you to think about. If you need more fundamentals, I have a bunch of videos on fundamental because I think this is very important for your test to pass or nursing school. And the last question, I just want to take you there. Always, you got to know this thing. When they give you older patients, you got to think about it. Suicide risk. There's a risk factors associated with suicide. Which information about the patient make them more at risk for suicide? Remember, he has COPD, he has tracheostomy, he's on oxygen, he has to use a cane, he live alone, right? What do you think? I live alone with the limited social support. Does that put the patient at risk of suicide? Patient has history of COPD, pressure ulcer, and hypertension. Does that put him at risk of suicide? He received home health visit twice weekly. Somebody come there every 2 weeks, every week, twice a week. And he uses a cane to ambulate. So he used the cane to walk. He's a deacon at the local church. What are the risk factors for suicide? What do you think? Fundamentals of nursing, questions and answers, using a case study, practice question, using our content to answer the question. Number 1, living alone is a bad idea, right? It's with limited social support. That's number 1. Suicide, if you're not married, you have a problem, right? If you don't go to church, that means social interaction, you have a problem. You have ammunition at home, we have a problem. You have no job, we have a problem. You have chronic disease, you have a problem, right? Those are the risk factors. So based on that, which of these do you think put this patient at risk? Well, living alone without social support is a problem. And a chronic disease, number 2, is a problem. Hey, she's getting a visitor every 2 twice a week, I think is a good thing. That's a social interaction. At least you can hope for towards somebody coming. I mean, you can hope for somebody coming in every twice a week to have some interaction and take care of it. So there's some hope, right? Um, Using a cane, walking with the cane does not put you at risk for suicide. I mean, it's not one of the risk factors. It's a trap. And having being a deacon at a church is a good thing. So that will put him in contact with people, and it will help him interacting. So these are 12 questions, fundamental of nursing, NCLEX practice question and questions and answers. We talk about safety. We talk about fire from oxygen. We talk about risks in terms of suicide, ambulation with assistive device, and some of the prioritization things you need to know how to suction a patient. This is Dr. NCLEX. Thank you for watching. If you like this video, you can share with your friends. If you want more, you can subscribe with Adapt NCLEX and get more content like that. Good luck in your exams and nursing school. Best of luck. Bye.